listening to the Pharmacy Podcast Network.
3, 2, 1.
Adverse drug reactions, or ADRs, are a serious issue in healthcare today. The pharmacist is the last line of defense to help prevent ADRs. A rising role of the pharmacist is the specialist who focuses on our children. Pediatric pharmacy ensures safe and effective drug use and optimal medication therapy outcomes in children up to 18 years of age. Currently, there are more than 1,450 board-certified pediatric pharmacy specialists, known as BPS. If you're interested in this expanding field of pharmacy, this podcast is for you. All right, everyone, let's give it up for our host.
Welcome back to this episode of the Pediatric Pharmacist Review. Much like our podcast before, we're continuing a theme of addressing topics related to pediatric neurology. And I know this has been an area of passion for me for many, many years, and I think for you too as well, Jenna. Is that correct?
Yes. From a personal perspective, having a sister that had epilepsy, there's a strong interest, and I've always kind of gravitated back towards it in my career, one way or another.
Yeah, it seems like you have so many stories, even personally in your family, we could chat about. And maybe that's for another podcast, another day. But today I'm excited. We've got some amazing guests with us that we go way back with as well. So today on the podcast, we have John Coakley joining us and Renaud Abusawa. Well, I am so thankful that you guys are joining us. Both of these individuals have been trailblazers in pediatric neurology and are doing some great work. So I'm excited to hear from both of them. So, Jenna, should we just jump right on in and let them introduce themselves?
Yeah, take it away.
Sounds
John,
great.
John, you want to go first?
Sure. So my name is John Coakley. I'm a pediatric neurology clinical pharmacy practitioner working at Texas Children's Hospital. I'm a neurology instructor for Baylor College of Medicine. I've been there for the past about 5 years or so, and I've been working kind of in the peds epilepsy space for about the past 12, 13 years.
Thank you. And Renaud, give me your background. I know we know each other personally, but I'm always blown away by your resume.
Awesome. Well, thank you, guys. So my name is Renaud Abusawa. I'm currently a associate professor at Rush Medical College and a clinical pediatric neurology and neurocritical care pharmacist at Rush Children's Hospital. And I've been here for a few months now, but I've been in the pediatric neurology and neurocritical care space in academia my entire career. So for the past 5-6 years or so.
That's awesome. Thank you, guys. We're extremely eager to learn from you and discuss the many nuances and different things you can do for refractory epilepsy. So what is, let's just start from the very beginning. So what is status epilepticus, and how does it differ from your traditional seizure? I'm gonna pass it to John first. We'll go back and forth to torture you guys.
Sure. So if you kind of think of seizures, just baseline, a seizure really refers to a sudden or uncontrolled burst of electrical activity that's taking place in the brain. So this just refers to the actual, electrical activity that's taking place. Seizures can be both motor seizures, so essentially seizures where you have physical movement, or non-motor seizures, where essentially you have that electrical activity that's taking place in the brain without showing any signs of physical convulsions. And they can occur in really one part or across the entire brain. Whereas status epilepticus refers to specifically a seizure that has lasted for greater than 5 minutes. And so this is something that is a variation from the previous definition of status epilepticus, where we would refer to as seizures that are lasting greater than 30 minutes of a period.
So you guys have both been involved in actually helping to shape how status epilepticus is treated in kids through your academic work, being involved in guidelines and many other things. So I think as we think a bit more about what status epilepticus is, it's important for us to also give some additional definitions. So is status epilepticus defined the same regardless of age, or are there differences among our populations? Renaud, maybe you can chime in.
Sure, that's a wonderful question. So status epilepticus has more than one definition. In the pediatric population, as Dr. Coakley mentioned, it's changed over the years. Pediatric status epilepticus typically is a similar definition to our adult population, and it can be convulsive or non-convulsive, whereas the other population that's often in the pediatric populations are neonatal populations. So neonatal status epilepticus is different, and oftentimes has different treatment algorithms. So in all honesty, it's a poorly defined condition, and it's been commonly correlated with continuous seizures lasting at least 30 minutes and or a series of seizures that have a total seizure burden over a given period of time. There really isn't its own separate definition outside of this, and it's still not very well defined, but it's oftentimes discussed separately because it is a different patient population.
Thank you, guys. So I know I had mentioned personally that I had a sister with status epilepticus, and it is life-changing for caregivers and family members. What risk factors are there for status epilepticus?
So I think naturally when we think of seizures, the first thing that will certainly come to mind will be epilepsy patients. So certainly we know that within the epilepsy patient population, noncompliance will certainly be something that we worry about. So patients who maybe they forget to take a dose or multiple doses of their medication, or let's say for example, now that we have the start of the new year, sometimes there's insurance coverage gaps, and so sometimes we're missing medications because of that, and that can certainly lead to obviously worsening seizures because you're not getting your medications. Outside of that, we certainly think of things like neurologic injuries. So working in the neurocritical care unit, we certainly see patients who present with traumatic brain injuries, and so having a head injury can certainly lead to presenting in status epilepticus. And then we also have autoimmune disorders that can certainly lead to it as well. I think there's been a big push for understanding the role of autoimmune encephalopathies. So things like febrile infection-related epilepsy syndromes, as well as drug toxicology. So either accidental or non-accidental ingestions as well.
So one of the things we're most interested in learning from you guys is related to the treatment of status epilepticus. So maybe we could start by getting a refresher regarding the first line treatments for seizures that are either repetitive or that are continuous. So Renaud, maybe tell us about some of the advancements we've seen in first line treatments of seizure events.
Absolutely. So the two primary guidelines that are used for the treatment of status epilepticus are Neurocritical Care Society published guidelines in 2012 and the American Epilepsy Society published status epilepticus guidelines in 2016. Of note, those are probably going to be updated hopefully soon. But as you can imagine, they're a few years old, to say the least. And so while the first line therapy is still in practice oftentimes considered benzodiazepines, there have been quite a number of new dosage forms for benzodiazepines that are now available, which are especially important for our patients to use for abortive therapy at home. So there are intranasal midazolam and diazepam products that can be used for your epilepsy patients to hopefully stop a seizure and not require them to come in to the hospital or the healthcare setting in general. So those are probably the biggest advancements in the first line therapy. Otherwise, you would still, even when I was taught epilepsy and status epilepticus, we were always taught benzos. So you always want to do your benzodiazepines first.
Now, I'm curious, with some of these new dosage forms, what have you seen the mix in your practice being in terms of prescribing? It used to be it's Diastat, right? That's what we had 15, 20 years ago when I started in pediatric neurology. That was our option. I'm curious, have you seen practice start to shift with the availability of new intranasal dosage forms? I know cost is an issue. There's lots of stuff. But maybe, John, what have you seen in terms of trends in your practice?
Sure. So I'll kind of lead first with that. I've worked for some of these companies, so just as a quick disclaimer, But certainly we have definitely seen changes within the prescribing world. I kind of think back to when I was first working as a resident. We even had patients who might sometimes go home and use like buccal midazolam therapy, so kind of inserting it into the cheek. Now that we have newer formulations, one of the good benefits there is it is sometimes a little bit more convenient to administer. If you think of kind of rectal administration versus some of the newer products that are able to be administered nasally. So it does provide a way of providing much more timely medication administration. One of the things that I typically will talk to families about, and one of the things that I typically will talk to my providers about, is also being aware of the fact that the medication dosage forms do differ a little bit. So, for example, the new Nasolam product has a 5 milligram dosage form. And then there's a new branded product, Valtoco, that comes with 5, 10, 15, or 20 milligram doses that you can provide. That's a little bit different from the way that we've been able to use Diastat in the past, because obviously when we think of Diastat, we think of the AccuDial, which allows you to dial in the dose for your patients. And certainly being able to provide timely and appropriate medication doses is something that we tend to harp on pretty heavily.
Thank you. And I will say, like, there's the factor of, from a family member's perspective, of like the embarrassment that an epilepsy patient has, when they're an adolescent and you're like pulling down their pants in public, because it's like, okay, risk benefit, somebody seeing your butt, or having my sister's seizures would go well into the 30-minute range. And so but as a family member, it was really horrifying to give that in public. So like when the nasal sprays came out, it was so exciting to me. And I find that, and I would love your input on this too, that, you can kind of finagle the insurance. Like if it doesn't cover Valtoco, you can do Nasolam. If it doesn't cover Nasolam, you can do Valtoco. And then of course, I'll let you guys talk about, there's obviously the age cutoffs too that come into play. And so that's not always a solution, but I'll let Renat just talk about the age cutoffs that come into play.
Absolutely. So because one is approved for patients 12 and up, and the other one, I believe, is less than the 6 years and up, they, for patients that are 12 years and older, you could potentially use one or the other. Whereas for patients that are in that 6 year to 12 year range, you really only have the option of using one of them. And so in my experience, recently, I have been better about getting these products approved for patients, especially, I think, because it's not only more efficient, but it's also definitely patient preferred. And a lot of our patients have tried some of the other ones, so it's usually not a hard sell, at least in my experience, for the insurance companies. But even with newly diagnosed patients that we've had, especially if they're in that older age range, since they are FDA approved for those age groups, I think it's getting easier and easier to bridge that gap and provide those patients those medications. Of course, there's always the discussion of what do you do in patients less than 6 years of age. And so that one, I think, especially in our patients that are 6 months to 2 years, I think, at least in my practice, we still use quite a bit of Diastat in that patient population. And then kind of the patient population in between, it varies. In pediatrics, we're always talking about off-label use medications. So I still see a bit of the intranasal midazolam product that's given via an atomizer in those patients because of the convenience. But sometimes those patients are using other benzodiazepines and other routes. So I think that we still have some ways to go, but I personally think the use of the nasal spray dosage formulations have revolutionized providing benzodiazepine therapy that can be given efficiently and easier, and kind of minimize that social stigma, like you mentioned, Jenna, for our especially our older patients.
I'm curious, do either of you know, if you're able to speak, are there studies ongoing to try to decrease those age limits? So is there new data that's coming that we should be watching for?
That's a good question. I don't know of anything ongoing. I will tell you, I have personally, and I'm sure other pharmacists have, I've personally had those conversations with drug companies and their representatives. But I'm not aware if there are any active research looking into either of those products. I don't know, John, if you have some intel that I'm not aware of.
Yeah, I can't quite speak to that.
Fair.
But I'll certainly say that, similar to Renata, I've definitely used it in patients that are well outside of that, age range for appropriateness. And it still works. Obviously, if it's worked rectally, it certainly will work nasally as well. So, yeah.
And is this like, I've been always trained, and I would love your insight on, if anybody's less than one, the excipients in Diastat could be essentially fatal to young children, especially obviously the really young ones. I feel like under one, I was always taught, like, don't use rectal diazepam or Diastat. Is there truth to that? What's your opinion on that? I'll let Renat go.
So I think I mentioned this earlier. For patients that are 6 months to 2 years, I have no qualms about using rectal Diastat. Especially, it's always a discussion with the provider and the patient and the patient's family about benefit versus risk of whether we think abortive therapy is warranted. But for those patients that need it, given the discussion of we want to abort their therapies, and oftentimes, especially for patients and their families who live really far away from a healthcare facility, we will go ahead and give them the rectal Diastat. If you talk about, I don't have that same comfort in the hospital. So if we have other formulations of medications, I don't typically use diazepam for that age group in the hospital, because we usually have IV lorazepam or other agents that we can use. But in outpatient, there's data using it up to or as young as 6 months of age.
Got it. Thank you.
Well, I would love for us to dive now into this idea of status epilepticus that we started to define beyond just that initial treatment. So let's say that we have one of our kiddos that comes to us and they're clearly in status epilepticus. What do our guidelines say in terms of the initial choice of drug? And is there one that's better than the other? So John, maybe we can go to you for this question first.
Sure. So I'll kind of lead with it depends on which guideline you're reading, because it is a slight difference between the two of them. But overall, I would say the kind of general consensus that you can take is there's not going to be a strong difference in terms of which medication that you receive in terms of your benzodiazepines. And the reason for that is going to be because part of it deals more so with the dosing that you're giving them. So obviously we'll probably end up diving a little bit into the ESET study at some point during this conversation. But what we learned from the ESET dosing is that we are often not providing patients with the adequate benzodiazepine dosage. And that is actually one of the major risk factors that probably leads these patients into going into status epilepticus. So if you think about that study, we showed that somewhere close to about 80% of patients get a less than ideal dose of lorazepam, and up to about 90% of patients for midazolam get underdosed when you look at those patients. Not only that, but if you think of the traditional status epilepticus algorithm, we typically talk about giving your first dose within, at that 5-minute mark. What we found was that we, in many cases, are not providing those medications in a more timely manner. And those are the things that actually lead to some of our negative outcomes. So if you're able to get the medication in a more rapid manner, you should be able to stop the seizures faster. So my kind of default is whatever I can give you fastest, that's what I'm going to lead to. So if you're thinking about it from the standpoint of, the outpatient setting, obviously it's going to be pretty quick for me to just stick something in your nose and press a button compared to taking someone's pants down. So certainly that would play a factor in terms of some of the ways that we think about the appropriateness of giving medications. And then on the inpatient side, then obviously you have a much more broader scope of medications that you can use, things like intramuscular midazolam. You can give IV lorazepam. You can obviously still give those same rectal and nasal products as well. And so I certainly will see, from institution to institution, there tends to be variances in terms of what is the ideal agent that they prefer for patients who don't have IV access. But I'll certainly say that IV lorazepam tends to be the ideal, agent of choice due to some of the pharmacokinetic properties of it when it's not on shortage.
And I would always cringe when I'd see in the ED that they gave IM lorazepam. I'm like, so what's your thought on that? Because you think IV lorazepam, IM midazolam. Is there literature that maybe I'm not aware of for IM lorazepam? I would love your guys' take on that from the guru, Renad.
So it is, intramuscular products are recommended in both guidelines. That being said, usually if we can get an IV in you quick enough, then IV is preferred just because intramuscular administration tends to be more erratic. And also sometimes, honestly, I've seen it in patients that are, they don't have as good muscle mass. And so I would be concerned giving something intramuscularly. But like John said, if that's my only option, something is better than nothing. So that's definitely something to consider. But yes, usually, I've seen it a handful of times, especially if they can't get IV access. And like we mentioned, they can reach for it. It's available. They have it and they'll administer it. I see that probably less so now just because of the availability of the intranasal midazolam, even in the ED. And most hospital settings, I think, have the one that you can draw up IV from the vials and use an atomizer. So I have seen that more and more used at a lot of facilities in institutions I've worked in, as opposed to the intramuscular products. But if you're on a deserted island, or some, not even just desert island, if you're in a place that's maybe more rural or that's the only dosage form you have, it is an option.
Got it. Thank you. So how is, this is an interesting topic for me because we actually, Perfecting Peds works within a neurology clinic, and these are a really, I feel like we see the refractory of the refractory. So I'm going to soak up like a sponge everything you guys say you're going to be teaching me. But how is refractory status epilepticus different than status epilepticus? I'll ask John this one.
Sure. So I think that what we kind of traditionally think of as refractory status epilepticus, it's essentially a patient that presents with persistent seizures despite receiving appropriate therapy. So this is essentially your patients that have most commonly gotten their benzodiazepine as their first-line agent, and then they've received at least one secondary therapy. So essentially, your patients that are kind of approaching that, do you give another second-line therapy versus do you start continuous infusions, which is a whole other debate.
Yes.
Yeah, there's definitely a lot to go into there. I want to go back, and this is somewhat of a good segue to the ESET trial for just a minute. For our listeners that aren't familiar with it, it stands for the Established Status Epilepticus Treatment Trial, and the acronym is ESET. ESET. And John, you mentioned some data from it that was really important for us, was data that the trial wasn't even really designed to measure, and that is looking at time to treatment for the first-line agents and also the dose. Really, this was designed to evaluate 3 other drugs, for status epilepticus. So, Renad, could you tell us just a little bit more about the ESET study and how that is now maybe caused us to pivot a little bit or think differently about how we approach status epilepticus treatment?
So like you mentioned, it was looking at treating, it's actually looking at second-line therapy with either fosphenytoin, levetiracetam, or valproic acid. And so really the discussion that it was set to investigate, and I think a discussion amongst a lot of clinicians, is which one should we use first? Which one is first line of these agents? And it's quite up to debate. I believe the highlights of the conclusions were that there wasn't really a big difference with valproic acid, and then the levetiracetam and fosphenytoin have can be given undiluted, but practices do vary quite a bit. And so again, it comes back to this concept of, if you had a choice between the three agents, there's going to be debates with clinicians of which one they prefer if all things are the same with patient-related factors. But oftentimes it comes into logistics of what do I have available readily and what can I give the quickest. I will say in the practice settings that I've seen, it's usually more of a debate between levetiracetam and fosphenytoin, with valproic acid not as commonly used. One of the things that the ESET study did not look at is brivaracetam. So that's another agent that is newer. It's kind of considered the cousin of levetiracetam that I think has emerging literature now as opposed to previously. So I still don't think there's going to be a definitive, quick answer for this is the best agent that you can use. But I think there are certain properties of a lot of these agents that make it products that can be given quicker, safely, and those are the things that you're really looking for kind of an ideal product.
Thank you. Again, I'm learning too. I feel like this is really, really enlightening, because I feel like it sometimes becomes providers' like preference almost. Like for me, like you don't even like know why. You're like, I don't know. I always reach for Keppra, and you're like, why? I don't know. That's just what I did. Like, and that's not the right thing. And so, but I feel like we all kind of practice like that. So some objective literature is nice, because you find we all have our favorite, and sometimes can't even give you a reason why. Like the neurologist I practiced with used it first. So that's really awesome. So what etiologies may push you one way or the other? I know you kind of alluded to it, but like, what are some reasons you would use one versus the other? I'll go ahead.
Oh, sorry. I wasn't sure if that was directed at me. So I think, so again, if everything else is the same in terms of access, typically we try to avoid using valproic acid in patients that are less than 2 years of age, mainly because we worry about the potential for underlying mitochondrial disorders that we're not aware of, specifically POLG mutations. However, I have worked with providers who, assuming you've ruled that out, you can use valproic acid. But generally speaking, if I have a patient who's less than 2 years of age, and I have levetiracetam or fosphenytoin or another product available, then I'm more likely to use that. And then there's always a discussion of fosphenytoin in the Dravet population. I know this is something that John feels very strongly about, so I'm going to let him delve deeper into it. But that's another condition where you might have a preference for one agent over the other.
Sure. So with fosphenytoin and Dravet syndrome, obviously what we're referring to there is a lot of the patients who present with Dravet have what's called an SCN1A channelopathy disorder, and most of those patients essentially have what's called a loss of function of that gene. So the kind of concern that, I always bring up, I do a status epilepticus pearls and pitfalls class, is the fact that the use of sodium channel blockers in this patient population can lead to worsening myoclonic seizures. And so for those that aren't familiar with the Dravet patient population, the old term for it was severe myoclonic epilepsy of infancy. And so essentially the major seizure type that we worry about is the one that could be worsened. But typically what I teach is that if a patient is presenting in status epilepticus, first, all bets are off, right? Because you're not necessarily talking about their chronic epilepsy management. Now, certainly that will play into what will I do after the seizure has been stopped. So that is something that's a whole other topic of conversation, because certainly then we would start talking about genetic epilepsy syndromes and, what else is there outside of just the SCN1A gene. So genes like SCN2A, SCN8A, et cetera, et cetera. And that might play a role in what I choose for your maintenance therapy. But from my perspective, I tend to still say if all you have available in your Omnicell or whatever your automated dispensing cabinet is phosphatidylcholine and it's a Dravet patient and they're presenting in status, you treat the status. So a lot of kind of, my thought process is certainly there are certain etiologies that we consider as things that kind of drive us a little bit away from therapies. But to me, I'm going to lean towards what's going to be able to provide patients with their medications the fastest. Certainly, we know from that same ESET data that the turnaround time, just as much as it's not great for first line, it's also not great for second line. And so when we talk about that kind of timeline, what I'm referring to is, your second line medication being administered somewhere around that 15-minute mark. We've seen with that ESET data that it was just as rough. When we talk about epilepsy and the response time, that can range anywhere between 30 minutes all the way up to an hour and a half. And so certainly time is brains, right? So we want to be able to get whatever medication that we can in as fast as possible. So that's going to be what I glean towards first. And then obviously from there, I'm going to think about are there other, for example, drug-drug interactions. And so obviously we know that phosphatidylcholine is a medication that's an inducer. So will that interact with other drugs? That's certainly one reason why we tend to lean a little bit more towards levetiracetam as one of our rescue medications. The other thing that I tend to think about is with us having a very large cardiac population. Shout out to cardialepsy, which is my original epilepsy position. Patients who have an underlying history of cardiac disease, sometimes we don't want to use phosphatidylcholine for those patients. And then when I think, from an infectious standpoint, we do utilize carbapenems. And so we do try to make sure we remind our epilepsy staff not to give valproic acid for our patients that have received a dose of carbapenems. So think drugs like meropenem. It only takes one dose to essentially inactivate that. So you then be providing them with a medication that's not going to work for them.
Yeah, I wish I had never seen that happen in clinical practice, but I can tell you that interaction is real, and you can't bolus your valproic acid levels back up for a week after you get that one dose of meropenem. So thanks for mentioning that, John. I think that's so important. I want to shift a little bit now to talking more about refractory status epilepticus itself and what's happening in the brain, and then talk about maybe some other drugs beyond those big three that you've mentioned, and I think some of them have already been mentioned. But what happens in the brain when we have an episode of refractory status? And does this have any impact on how we approach treatment?
Absolutely. So this is one topic that is very near and dear to my heart, and I love talking about it to my students, but also to providers. So there's this theory, I think now it's been coined the receptor trafficking theory, but essentially what it does is that as status epilepticus continues and it actually becomes essentially harder and harder to treat that status. And the reason is that you have these pharmacodynamic changes at a molecular level in the brain where you have GABA receptors that become internalized. So GABA receptors are the ones that we use, that we target in our initial treatments with benzodiazepines primarily, and those become internalized. So essentially, you're going to need higher doses and constant bombardment of those GABA receptors for it to work, which is why you see continuous infusions of midazolam later in the algorithms. But the other cool thing that occurs kind of at the same time is you get an upregulation of this other receptor called NMDA receptors. And this is really cool because it essentially gives us another drug target that we can use, and there's a drug that targets this receptor specifically known as ketamine. And so we can talk about ketamine a little more in depth. It's an area I've done quite a bit of research in, and I'm very interested in, so we can talk about it quite a bit later on when we talk about super refractory status and refractory status epilepticus. But that receptor trafficking theory is awesome because it essentially gives us a pharmacological mechanism of why we choose the drugs that we use to treat as time goes on.
I feel really stupid. I never knew that. Like I'm sitting here like, I mean, I know obviously like the algorithm, but I never knew the reason that it works is because of the upregulation. So mind blown. Always learning from you. So thank you. So John, this is to you. I know just talked about ketamine, which is amazing. But what are some other drugs that we use for refractory status epilepticus? And I know Renat had alluded to some of these drugs a little bit.
Sure. So she mentioned brivaracetam already. So this is essentially we think of as kind of like a cousin to levetiracetam. This is a drug that's a little bit more selective to what's called SV2A. SV2A is essentially what leads to glutamate release in the brain. And so we know glutamate from the standpoint of it is one of our excitatory neurotransmitters. And so that's one kind of target that helps to, make the brain a little bit more almost prone to seizures. And so the theory behind, levetiracetam versus brivaracetam comes up all the time in my ICU. Which one should we use? Why should we use it? Does it make a difference, between the two of them? I'll certainly say, it's not officially studied, but there are some pharmacokinetic differences that I'll point out. Obviously, by having a little bit more SV2A selectivity, what we're thinking of there is it's specifically helping to decrease the amount of glutamate that's being released into the brain. So it's helping to kind of decrease that overall excitability. One of the other areas that I think we've kind of almost debunked a little bit is the rate of how fast we can administer it. So certainly we typically will talk about brivaracetam being something that can be administered essentially as an IV push, over a period of less than 2 minutes. Casey Adams and Tori Greenhouse did a study looking specifically at doing IV push levetiracetam because, I'll say back in my days, when I was a resident, we were not allowed to administer rapid infusions of levetiracetam because there was a big bright label on the sticker that said must be diluted. And so essentially the concept of that is when the drug was first, released, we knew that that product has a relatively high osmolality. If you kind of think of it compared to, say, for example, 3% sodium fluoride, it's about the same osmolality. So what we found was that if you give it too fast, it can be painful, right? Which is not too dissimilar from other drugs that we administer through peripheral veins as well. But that was one of the reasons why it was on that label. Now, certainly, kind of the argument that I've had, amongst different institutions that I've consulted with is, while yes, you can certainly say that this is something that's a little bit, more painful to administer if you're giving it too rapidly. If the patient is seizing and you're worried about protecting their brain, I'm not necessarily worried about the comfort, and the patient might not necessarily be conscious to tell you that they're in pain. So it's not something that's been associated with tissue extravasation, which is certainly the other aspect of osmolality that we worry about. As far as I know of, knock on wood, I've only heard of 2 cases out of hundreds of thousands of doses probably that have been given, at this point, that haven't really shown that there's a high risk for tissue extravasation with it. So much so that there's even concentrated administrations of levetiracetam that have been given, for example, in the hospice, sector. And then the third kind of area that we tend to think about is really how fast does it get into the brain. And so if we're comparing that, if we think of kind of the traditional way that we used to administer levetiracetam, it's going to be given over about 15 minutes. And it can take another 15 minutes to get into the brain. Versus if you're giving your brivaracetam, you're giving over 1 to 2 minutes, and it takes that same 1 to 2 minutes to get into the CNS. So theoretically, it will get into the CNS a little bit more rapidly. It will have a little bit more impact specifically on those SV2A receptors. And so you're looking at all things that are pharmacologic advantages of the brivaracetam kind of structure, and it's something that we're seeing that some practices have already started to adopt. We do have the ability to do brivaracetam and levetiracetam at our institution. So I won't say that we do it for everyone. We're not saying that everyone has to get levetiracetam, but it is certainly something that is becoming a little bit more of a conversation. I think probably the other aspect of the conversation is, what do you do with dosing? There is a study that says that roughly about 10 to 15 milligrams of levetiracetam is equal to about 1 milligram of brivaracetam. And so the biggest question that has come from other institutions is, well, does that mean that you do 2 mg per kilo, which is, the equivalent of about 20 to 40 mg per kilo of levetiracetam? Do you give 4 mg per kilo, which is the equivalent of about 40 to 60 mg per kilo of brivaracetam or levetiracetam, or do you give higher than that? I will certainly say in my practice, I tend to use neither of those doses, and I'm a little bit more aggressive.
I was
My
going to
thought
say,
process is
we would give it
okay.
crazy. I said we would give it like it was water, Kepra.
Yeah.
It's nice that it's, I know there's side effects, but a relatively benign drug. So I feel like it's a drug we can comfortably be aggressive in.
Certainly. So certainly, with levetiracetam, we give as much as 60 mg per kilo. I've typically said that anywhere in the 4 to 6 mg per kilo range is going to be your equivalent for brivaracetam. We do know from some of the kind of preclinical studies that they have given doses up to 10 per kilo of brivaracetam. We certainly know that there can be a little bit more kind of sedating effects, from that standpoint. But if I'm looking at a patient who is presenting in status epilepticus, they're probably going to have a little bit of sedation or be post-ictal anyway. So that's not necessarily something that would prevent me from using that. But what would potentially drive me one way or the other would be things like whether or not there's drug-drug interactions. We certainly know that levetiracetam doesn't have any, whereas unfortunately brivaracetam can potentially have some drug-drug interactions, and it certainly could be something that might steer me away. Let's say, for example, if the patient presented in liver failure, those are going to be kind of some things that we'll think about. The other one that we'll probably think of is lacosamide. Lacosamide, it's a little bit different from fosphenytoin in the sense that we think about fosphenytoin being a fast sodium channel blocker. Lacosamide is a slow sodium channel blocker, so slightly different, but still kind of in the same realm in terms of how it works within the brain. Probably the biggest question that comes up with lacosamide is really how do you dose it in the peds population? So I think kind of when I first got introduced to lacosamide, there are some institutions that say, we do a 3 per kilo load or a 4 per kilo load. And, there's kind of that discussion of, giving about 3 to 5 mg per kilo as kind of that standard dose. When I think of it from the standpoint of status epilepticus, again, I'll certainly say that I'm a little bit more aggressive. We tend to give doses of about 8 to 10 mg per kilo for our status epilepticus patient population. Specifically in the peds population is where we've seen the difference in that response. It's kind of similar in the sense of we talk about whether or not it can be given as a rapid IV push or whether or not it should be given over, let's say, a 15 to 30 minute infusion. And the biggest kind of conversation around that is what does it do from a cardiac standpoint? And so we typically will associate lacosamide with PR interval prolongation. Certainly on the adult side, they have moved a lot of institutions towards doing IV push administration and have not run into significant effects. But we certainly do know that the risk of PR interval prolongation can increase the more rapidly that you give it.
Okay. And this is just a clinical question. When everyone, when they're on lacosamide, do you do a baseline or recommend to do a baseline EKG for all patients?
So that'll likely vary depending on your institutional practices.
Okay.
I'll certainly say when I first started using lacosamide, that was our practice just because it seemed like it was, honestly, it was just good, good practice, a good habit to have. I can certainly say that patients who are not on PR prolonging medications and those that don't have some sort of, underlying cardiac history probably shouldn't present with a prolonged PR interval. So it hasn't been something that, if I'm really, really worried about it, can I still give it without getting it right away? It certainly can be done. But I'll certainly say it depends on the institution there. The only other thing that we kind of typically will talk about is going to be what does that mean for the patient? And certainly if we're kind of comparing it to fosphenytoin, we typically will say that it has a higher incidence of dizziness.
Okay, cool. Thank you. That's, again, I'm kind of being re-submerged into the medically complex epilepsy patients here through our company. And it's a steep learning curve. These meds are you kind of get used. And what I'm finding is the practices geographically are so different that you're you're used to, what your New Jersey neurologists do, then you're thrown into PA, and then then Minnesota. So it's, again, just getting used to their go-tos, and it's really cool because I'm relearning a lot. So thank you for that. So what are the ways that as pharmacists we can optimize care in general, Renan?
So this is also a topic near and dear to my heart. And I think it's one that we need to continue talking about. Some things kind of off the top of our heads. One, just because I am, I think, an educator by nature, but teacher by blood, so to speak. Education is always really important, whether it's education to providers or especially providers that don't necessarily take care of medically complex patients or epilepsy patients. I think it's important to talk about the ever-evolving drug therapy options that are in our arsenal, but also the change in guidelines and emerging data that's coming out. So that's always one I will throw out there. Some other ones that are probably a little more logistical, talking about your institutional process. So both of us have constantly alluded to the fact that there are differences. There's variability in institutional practices. And I think what's important is having an institutional process, right? Putting all your stakeholders together in a room and saying, hey, this is a medical emergency. As John so eloquently mentioned, time is brain. That's not just for stroke. It's also for status epilepticus. Mm-hmm. So coming up with algorithms to minimize and processes to minimize the factors that we have seen now in evidence that are leading to poor outcomes. So time to administration and appropriate dosing. Neither of those things should be occurring in our healthcare systems if hopefully there's education and adequate training and institutional processes. Something else that I've seen at a few institutions that I've been at, and I think it was the case in Texas too, is a lot in patients who have a status epilepticus in the hospital, they will call a rapid response or a code response to kind of hopefully, in theory, expedite care essentially in those patients, especially if they're not already in an ICU. We already talked about processes, but treatment algorithms is important as well. So at every institution I've been at now, I think there's more and more developing status epilepticus treatment algorithms and protocols, but I think I've always been involved in those and updating them. So having those available, and again, making sure that all the stakeholders that need to be involved are involved, including clinical pharmacists, especially if you can get a neurology trained pharmacist, that'd be great. And then the other one is access. So we always talk about medication access from an outpatient perspective, which is just as important when we talk about abortive therapy for status epilepticus, hopefully preventing them from coming into the healthcare system, but that also is within our healthcare systems as well. So again, we keep talking about whatever you can get the fastest and into the patient. And so when we talk about medications that are available in your ED, Pyxis or Omnicell, or your ICU, Pyxis or Omnicell, there could be some variations, and there could be variations also in terms of who has access to those. So can a nurse pull those medications and administer them versus does it need to be somebody else? So those are things that I think we should think about to maximize in hopes of optimizing care for these patients.
Renan, those are fantastic reminders. And as a peds neurology trained pharmacist, I couldn't have said it better myself. I want to move us now to the wild, wild west of status epilepticus. Can we go there? All right.
My favorite part.
What I'm talking about here is super refractory status epilepticus. Okay. So maybe, John, I can turn this to you, but could you give us a definition of super refractory status epilepticus? And then after that, we can maybe talk about some of the drugs that we've already mentioned and some of the craziness that happens. Again, it seems like every practitioner, every institution handles things differently here. So, John, tell us what you know.
Sure. So I'll kind of just start with, how do we really define it? And so I'd say most, general consensus consider super refractory status epilepticus to refer primarily to those patients that have been in status epilepticus for 24 hours or Patients who have essentially required at least one anesthetic therapy, they're still in status epilepticus. And so those can, also include patients, for example, that have recurrence of said status epilepticus if you've tried to withdraw or remove that anesthesia agent after you've started that infusion.
I guess now we can dive into the drugs. So, Renaud, I know you introduced us to the idea of using ketamine, and I think that's become, in a lot of places that I've seen, one of the go-tos here. So can we use it as our primary agent? What's your opinion on that?
Oh, okay. So if we're talking about my opinion, I have been known as two things, and one of which is the ketamine lady. And it's not because I personally any experience with it, but more because I very rarely think it's not a good option to use. That being said, there are some scenarios that you don't want to use it in. I can talk about those first, and then we can kind of talk about ketamine. So patients who have an underlying cardiac condition or abnormality, if you have other agents that are available, you tend to not want to use ketamine because it can cause some tachycardia and elevation in blood pressure. Although oftentimes that's the reason it's actually beneficial, because most of our patients are hemodynamically unstable, and so you don't want to give them something like a barbiturate or a benzodiazepine that will plummet their blood pressure. That being said, if the reverse is true, you might want to consider something else. And then there's always the concern with psychiatric conditions or the risk for emergent syndrome or delirium. In my personal experience, I kind of have the same philosophy that John does in other respects, is they're in status. So I'm not concerned with that right now. And it has a pharmacological benefit in terms of taking advantage of that upregulation of the NMDA receptor. So I'm going to use it in that scenario. I'm trying to think. There's a lot of other pharmacokinetic and pharmacodynamic properties that we kind of alluded to that make ketamine a good option. One of the things is, even though typically in practice, from what I've seen, once we start talking about super refractory status epilepticus, we're talking about potentially putting them on an anesthetic infusion, which usually requires some type of respiratory support. That being said, ketamine, unlike the diazepines and the barbiturates, at certain doses doesn't actually have any effect on the respiratory drive in terms of making it less, like you would be worried about with propofol or benzodiazepines or barbiturates. And so if used early enough, I've used it in patients who are fully, not usually status epilepticus, but they're awake, and you use doses and they don't require ventilator or respiratory support. But that's not usually the case if you're using it for super refractory status, because we've already kind of exceeded that. There's been a lot of literature looking at essentially using drugs that target different mechanisms, especially GABA and excitatory, so something like your NMDA receptors early on, to help with essentially quicker time to seizure termination. So that would also potentially be an advantage with this agent. It's readily available. Most people know it for its sedative properties and even analgesic properties. So it's going to be available in most institutions. It's just one that I think we have emerging comfort in with a lot of providers. I think that's something that is still developing. But as a drug, it's been honestly used for a very long time. And from a pharmacological perspective, has a lot of potential benefits for its use compared to some of our other agents. That being said, we can still use it in conjunction with a lot of these other agents if you need to. Oh, the only other thing I did want to mention, is there's a big controversy with it elevating your intracranial your intracranial pressure. So for patients who have traumatic brain injury, the concern is that you, and they sometimes will develop status epilepticus. The concern is using ketamine will make that worse. And in actuality, I've used it to actually decrease a patient's intracranial pressure in TBI patients, because you can actually get burst suppression with ketamine, unlike, well, most people don't know that, just like you would with barbiturates or barbiturates mainly. But so that's one that's been kind of debunked in the literature in recent years, but is one that every now and then will still be a conversation, especially in those TBI patients.
Well, thank you. I think there's a lot of just interest around ketamine. I know we're using it for so many other reasons too. Like we're seeing it in mental health, as outpatient infusions. And I wonder, and I don't know if there is anything like, to use it in something like, just epilepsy in general, because I feel like when you get really towards the refractory patients, we really do some wonky things that maybe wouldn't traditionally work, but like I just gave patient, we just did sub-Q IVIG for a patient, and that's working. So I feel like a lot of the non-traditional things, when I think of something like, again, the ketamine infusion, what we've seen in behavioral health, I wonder if that will bleed over into epilepsy. I don't know if you have a thought on that.
No, I was thinking, one of the things, since we are talking about the Wild Wild West, some of the things that I've done with the blessing of some very cowboy-like providers is using ketamine dosing, ketamine bolus dosing. So if there's a patient who we think we're going to have to go to intubate them, we think we're going to have to put them on, some kind of infusion like for their status epilepticus, I've done it a few times when I get the blessing. We've done ketamine boluses, and, I'm kind of into the global health spectrum these days, but in other countries, there is some data and some institutions, I think in Italy, where they do have protocols where they'll do the ketamine bolus dosing for status epilepticus. But I think that probably classifies as Wild West in the U.S. for now, but who knows, that might change. In terms of the mental health space, it's interesting you mentioned that, because like I mentioned earlier, one of the things that I think some providers have concerns about is the effect of ketamine on kind of other aspects of like neuropsychiatric aspects. But again, in status epilepticus, I don't think that's as much of a conversation. It's more of long-term management or other conditions. But it's interesting you mentioned that.
We appreciate all of that information. It's fantastic stuff. So I'll just speak for myself. Being in peds neuro and knowing the two of you for so long, I could talk to you guys for like 5 hours on this, but we've got to land the plane at some point. So let me turn to John and just simply ask, are there any other things related to super refractory status epilepticus treatment that you'd love to throw in there? I feel like we're remiss if we don't say something about propofol and propofol infusion syndrome in kids. Maybe you can comment on that, but anything else that you would want to add here?
Sure. Yeah, I'll definitely piggyback. I'm very similar to Renan in the sense that I love ketamine for all those same reasons. I tend to kind of be the same way in terms of our practice, particularly, with our trauma patient population. We can see that it has some neuroprotective effects. And that's another area that's kind of hotly debated. But I tend to remind our providers that, especially when we talk about patients are presenting with super refractory status epilepticus, these very difficult to control seizures, ketamine can also give you some additional benefits in terms of helping to prevent the release of those inflammatory cytokines, which will then lead to secondary damage. So we're thinking about some of the other agents. Certainly, penobarb is one that we tend to think about very commonly in terms of something that we use for barbiturate comas, and it does provide you with it does have the ability to block TNF alpha, but ketamine does block your interleukin-1 and interleukin-6 as well, so it gives you a little bit more of a bang for your buck. Penobarb is something that we use very heavily in the peds patient population for those patients that don't respond to midazolam infusions. I find that most institutions kind of go to midazolam first, and then they kind of debate, penobarb versus ketamine in the kind of refractory sense. Certainly, penobarb, we typically talk about the incidence of hemodynamic instability. I kind of tend to teach, think of your benzodiazepines as your machine guns. Think of your barbiturates as lasers. So they're going to give you a little bit more of of a potent inhibition. So certainly that can lead to a little bit more hemodynamic compromise. And obviously the secondary kind of thing that we're thinking about is, what does this mean from a toxicity standpoint? So certainly the same way that we talk about not particularly wanting to use diastat in very young patients, there's also a big push to prevent some of the kind of neuroapoptosis concerns with pentabarb. And part of that can be from the fact that these patients can get propylene glycol toxicity. There are a lot of different debates in terms of what does this really mean in terms of how high can we go for those infusions. One kind of way that I typically will teach my providers is that if you put a patient on 1 mg per kilo per hour, it provides you the equivalent of about 200 mg per kilo per day of propylene glycol. And so obviously the risk that we typically think of is, are you going to be at risk for acute propylene glycol toxicity, which if we're thinking young patients, we often kind of associate with that 200 mg per kilo per day for a chronic period, or 400 mg per kilo per day for a larger patient for a chronic period, or 500 mg per kilo per day, which is the equivalent of about 2.5 milligrams per kilo per hour for acute toxicity. And so it doesn't take long before we can build that risk up. Certainly, we tend to do a lot of bolus and titration for our patients on pentabarb. And then kind of the same thing when we think about propofol, we typically will talk about the risk for propofol-related infusion syndrome. And so kind of the same thing there is it's oftentimes associated with how high of a dose you're going. And so the typical kind of thing we think of is about 60 mics per kilo per minute. When you're above that, the longer you are above that, the higher that risk is. So certainly with all of these drips, the biggest thing that we're trying to do is hit the patient as hard as we can, stop the seizure so that we can come back down on the dose, so that we can avoid some of those same concerns. And then kind of similarly with propofol, I kind of have to throw out there as well the concern for patients that are on ketogenic diet. We certainly know that propofol is that nice, white, milky-looking substance, and that's because it has fat in it. And so certainly, there is the concern of, what does this mean for patients who could potentially have mitochondrial disorders or patients that are on ketogenic diet. There is a case report that has shown that there was a fatality in a patient that received propofol at high doses that was on the ketogenic diet. So we do have an IRB that's actually out specifically investigating that. But it is something that we certainly say that a lot of additional caution is warranted. So you want to make sure that you have a very well-trained ketogenic diet team if you are getting that far down the algorithm in terms of what can work. And kind of similar, when we think of pentabarb, that propylene glycol can potentially drop your beta-hydroxybutyrate and make it a little bit harder to control your seizures, because obviously you need these patients to be in ketosis. So you want to try and minimize the sugar that they're receiving.
Well, thank you guys. I can personally say I never felt so dumb and learned so much. So thank you again. It's been really amazing. And I really respect you guys and have appreciated your time you've spent today. If you had one closing thought for in regarding status epilepticus, what would it be? If you could tell a clinician one thing, what would be your clinical pearl for them? Or how about we say our fellow pharmacists?
I hate to steal yours, but I honestly think the one that I use often is time is brain. And also be aggressive. Like, it's a medical emergency. So, I hate saying this, but hit them fast, hit them hard, all appropriate doses as quickly as you can, because it really is a medical emergency.
Yeah, I would definitely agree there. I've certainly been a strong advocate for optimization within the pharmacy space. And so by that, I mean teaching facilities that not only can the majority of these medications, when we're talking second line, be administered undiluted. If they can be administered undiluted, that also means that you can put them in your automated dispensing cabinet so that you don't have that delay. That's actually something that has been studied, and we've shown that it can reduce the amount of time that it takes to administer by almost an hour. So certainly that's probably the biggest takeaway. And then obviously the second thing would be honestly being familiar with ketamine, because from a pharmacologic standpoint, I'm a strong advocate for it for a reason, and that's because of the pharmacologic properties that it plays into with refractory status epilepticus patients.
Well, thank you guys. We've had a wonderful time, and I hope you guys have a great day. And I can honestly say I learned a lot.
Thank you for having us. It was our pleasure.
That's all for today's episode. Thanks for listening, and remember to subscribe on Apple Podcasts and leave us a review.